Good afternoon, everyone. We'll just wait for 5 more minutes and start the session. Generally, we expect about 170 to 200 participants. Is that okay, ma'am? Dr. Spandana and Dr. Hariprasad, sir?
Yeah, we are fine, Vinila. I think Kritika is facilitating the session,
Yes.
so I'll leave it to Kritika to take over.
Yeah, we can wait 5 minutes. Just see.
Yeah, sharp 3-5 will start of the session.
Yes.
Thank you.
Hello. Good afternoon, everybody. I am Dr. Kritika Rao. I'm an assistant professor and a lead for pediatric palliative care services at Kasturba Medical College, Manipal. And I welcome you all on behalf of the team involved in Indian Academy of Pediatrics Pediatric Palliative Care chapter, and welcome you to the session 5 of this course. Before I begin this class, a few Zoom etiquettes that we should all follow. I would request everybody to position your video camera appropriately so that you're visible. Mute your microphone if you're not speaking and remain muted throughout the meeting. And if you would want to ask a question, please raise your hand. Keep the video camera turned on throughout the session. Please rename yourself. This is important to mark your attendance for the every session, and 70% of the attendance is a mandate to complete this course. I request all of you to type in your questions in the chat box, and during the session, we will answer them then and there or read out to the faculty after the session during the Q&A session. If there are any questions that are unanswered during the session, we might get back to you in the chat box. Post-test along with the recorded video will be shared to you at the end of this session. And I would take this opportunity to introduce our speaker, Dr. P.G. Hari Prasad. He is Professor of Pediatrics at Government Medical College, Ernakulam, and Dr. Spandana Raila, who is the Education Lead with the Two World Cancer Collaboration and a Pediatric Palliative Care Specialist at the Bayat Abdullah Hospital in Kuwait. And today's topic is on common symptoms and disorders in children suffering with chronic debilitating neuromuscular diseases.
Yeah,
I hand it over to Spandana and Dr. P.G. Prasad sir to take this forward.
Dr. Kritika, we lost you.
Can you hear me?
Yeah, you're audible, Kritika.
Yeah, so we begin this session with Dr. Spandana Raila and Dr. P.G. Prasad sir taking it forward.
Ma'am, we lost you in between. So
I can hear her, Vinila. I think maybe the internet is a bit shaky. Can you share the slides?
Yes, ma'am. And before meanwhile, I'm sharing the slides, there is a small announcement. It looks like Dr. Avinash, Dr. Anvesh, Krishna, Sharda, and Miglani. So your microphones are not connected. So if they are not connected, maybe you have to tell your friends like they can't neither hear neither speak. Please, I request all of you to please tell your friends to reconnect once again.
Good afternoon, everyone. So nice to see you all. And I know you all have busy practices and making that effort to join and learn new things. I think that is something that should be congratulated at the outset. And so nice to meet you all. Today, we are going to speak about one of the most important subgroup of children we see in palliative care, which is children with neurological diagnosis. Next slide, please, Vinila. I'm sure you have seen this picture. This is a pie chart again showing about palliative care diagnosis in children. And if you look at it, the neurological conditions, even though it shows only 2.3%, if you look at meningitis, it's close to 12%, and even HIV has neurological manifestations. And neonatal conditions, if they make through the neonatal period, usually end up with a lot of neurological manifestations, and congenital anomalies, as you know, also include neurological. So it does include a huge percentage of neurological conditions. And the other thing we have to remember in our practices, when a child has cancer or some, life-threatening condition, the duration that they survive is smaller, whereas neurological condition, they end up living longer and with a lot more symptom burden. So that is the other reason why a lot of times it does happen. I can see someone has posted audio is not clear. Is it so for everybody?
No, ma'am, it's clear.
Okay.
We can hear you.
Yeah, thank you, Kritika. Next slide, please, Vinila. And also one thing we do, next slide, Vinila. Sorry, thank you. These are some statistics. These are from the place where Dr. Hari Prasad sir works in Kerala. And he has taken from the OPD how many children we see sometimes, especially when they come for follow-ups. And as you can see, 61% are neurological illnesses when you consider palliative care diagnosis. and a huge number of cerebral palsy and post-meningitic sequelae and congenital malformations. So I think irrespective whether we do palliative care or not, these are some children that we are going to see, and we can apply palliative care principles for these children. Next slide, please. So in the initial sessions, we discussed about various categories of pediatric palliative care, the 4 categories, if you remember. So can you type in the chat, in which category do you think neurological conditions fall into? Anyone on the chat? Do you want to say like which category few of the conditions can fall into? Do you remember the various categories? Category 4, yes. Category 4, okay. Okay. A lot of you are going with category 4. Let's see what actually they fall into. 1 second. Vinila, next slide, please. I forgot that I have to ask you, and I was trying to change the slide. Sorry. So these are the 4 categories of children. Next slide, please. If we go into individual categories, the first one is life-threatening. Curative treatment is available, but may fail. Next slide, Vinila. So if you think about it, I know the common example given is cancer, but also TB, meningitis, meningoencephalitis, sometimes even Guillain-Barré syndrome, right? They respond very well to IVIG, and after rehabilitation, they survive. But a lot of times in our practice, we see that the treatment, the curative treatment doesn't work, and they end up with some sequelae. Next slide, please. And you must have seen the graph in which they deteriorate. Vinila, next slide, please. I think it is difficult when you're admitting people, Vinila. Maybe that is why there is a lag. Next slide. Yeah. And if you look at category 2.
Swati is admitting team, ma'am. Sorry.
Okay. Yeah, no problem. Category 2 is a long period of treatment. Again, the idea is to prolong the life, but we expect that they might die early. So for example, muscular dystrophies like Duchenne muscular dystrophy, they use steroids, they use other drugs to try and prolong the life, but we still expect them to pass away in their 2nd, 3rd decade of life. And some of the congenital myopathies. So even category 2 has diagnosis with neurological condition. Next slide, Vinila. And when you look at the graph, sometimes they worsen, and the more number of times they have these crises, for them it is difficult to come back to their original condition, and one of these crises can lead to death. Next slide, please. Yeah, category 3. Here, these are progressive conditions, and these are palliative from diagnosis. So metabolic disorders, some mitochondrial disorders, as you all know, neurodegenerative conditions, and even sometimes syndromes with neurological manifestations. These fall under category 3. You diagnose them and you know there is no curative treatment. I know some of the conditions now have enzyme replacement gene therapy, but in our context, I would still consider them to be palliative. Next slide, please. So these children usually, once they start worsening, they do not come back to their normal condition, and they worsen over the period of months or sometimes years, they pass away. Next slide. And a lot of you said category 4, which is very true. And that is a severe disability, and they are not expected to die because of the condition in itself. But a lot of complications occur in the meanwhile, and that leads to death. So all our cerebral palsy children post hypoxic injury at the time of birth or after, and severe brain malformations such as lissencephaly, they tend to live for 3, 4, 10 years, but they have complications, and death is expected. Next slide. Yeah, and these children, again, at the time of birth, they might be a little stable, but over a period of time, they worsen and that leads to death. Next slide. So let's go through a case scenario and you can keep typing on the chat. I think that would make it more interesting rather than just a didactic. So I'm sure all of you must be seeing cerebral palsy kids in your OPDs. So if you see a 14-year-old girl, and what would be some of the signs and symptoms that you're looking out for? And as you all know, any good management begins with good assessment. And that is why one of the sessions we spoke a lot about how do we manage pain? And to manage pain, we need to assess pain. And you spoke about some scales at that point. In the same way, when you see a 14-year-old girl with cerebral palsy, yes, I can see some chat coming up. Inability to do daily activities, excellent. Feeding difficulties, seizures, nutrition, spasticity, yes. GERD, contracture, menstruation. Wow, Menak, I did not expect that to come up so early. That's wonderful. Contractures, constipation, urinary retention, yes. Recurrent chest infections, bladder and bowel care. Very true, especially they end up in diapers a lot of times, and yes, that can cause bed sores, diaper rash, communication issues. Excellent. Even drooling of saliva, silaria, good. What else has come up? Lot of wonderful answers. Dental issues, self-injury, yes. Intellectual disability causing other issues like communication and child putting themselves in a risk sometimes. Mood instabilities, yes, that's a huge thing. And sleep disturbance, behavioral issues, right? I also see pain assessment issues, right? Because they cannot verbalize a lot of time that they're feeling pain, and there are also behavioral issues coexisting, and it makes assessment very, very difficult. Yes. And this is a lot of experience, right? All of us. So next slide, please, Vanilla. So as you all know, I don't have to go into the pediatrics of this. There are different types of cerebral palsy, and the one with a little better prognosis in terms of intellectual disabilities, the hemiparesis one and the diplegia one. So why I'm saying this out loud is a lot of times our team members, even though we know their intellectual capacity can be near normal or better than us sometimes, just because they have a physical disability, we end up thinking they are slow and we might not treat them like a typical child. So just being mindful that their intellectual capacity is something we do have to remember, and sometimes even point out to the parents and the caregivers becomes very, very important. Next slide. And as you all mentioned, one thing we haven't brought up is dystonia. I think that is very important, and we will talk a little more about it as we go forward. And seizures, you have said spasticity. There is one other symptomatic diagnosis we have, which is called neuroirritability. And these are the children who are crying. And when you try to look out for a cause, there is no organic cause that you can find, because you have already mentioned UTI, you have mentioned dental issues, you have mentioned other contractures, spasticity. So once we try and treat all of those, and look for all of these, and also sometimes these children have gallstones and kidney stones because we are giving them calcium and not looking at any other parameters sometimes because of where they stay. So when we rule out all the organic causes, if the child is still crying or is still in discomfort, we call it neuroirritability. And this is something a lot of times I have seen as a pediatric palliative care a physician, that pediatricians we tend to miss because we think, okay, the child is just crying, but this is something that can be treated with medicines and also some non-pharmacological measures. And as you already said, all the other issues along with audio-visual impairment. So again, this is something we have to highlight, because when there is no sensory input, it becomes very difficult for the child to communicate. So we all need to perceive light to have our circadian rhythm set and have good sleep. So when that doesn't happen, it gets difficult that these children might have sleep issues because of that, sometimes requiring melatonin or benzodiazepines, and sometimes they don't have auditory input. So, I know as pediatricians, again, we check for their, check them through BERA, OAE, but there are times we have seen children in rural areas, everything is normal. It's just that their hearing is not normal and no one picked it up and they don't go to school because of that. So things like that, again, it becomes very imperative that we look at the child as a whole and not just as the sum total of their problems. Vinila, can you click it once again? Yeah, and also when we look, this is something we always look for, and if affordable, always trying to find out if there is a metabolic cause and if it is something that runs in the families, and if possible, doing a genetic study. Next slide, please. So this is GMFCS classification, gross motor function classification system. It always helps just to know that this exists and to put the child in one of the category. This helps if the child is in rehabilitative phase, it helps us to see if the child is improving or not improving, and also sometimes to provide aids for the child, what kind of walking aids, mobility aids that can be provided for the child. These are some things, and also for prognostication. So a Duchenne muscular dystrophy child, as you all know, before 4 or 5 years, they are at level 1. But as they come close to 7, 8 years, they come into level 2, and over a period of time, they end up in level 5. So just being mindful of that, that there are scales and ways to document so that the person who is seeing next, or even we, over a period of time, see what is happening with the child is very important. Next slide, please. And also for spasticity, there is a modified Ashworth scale. Again, when we are starting baclofen, when we are starting any benzodiazepines for spasticity, it's always important that we document how much the tone is before and how they respond with the initial doses. Next slide, please. And we are going to talk a bit more about dystonia, but dystonia is a huge symptom that we do not realize exists. And this is something, again, as a pediatric palliative care physicians, when we do rounds in hospitals, tertiary hospitals, we see children in dystonia, and a lot of times dystonia is mistaken for seizures. Dystonia is mistaken for spasticity. Dystonia is mistaken for even just pain and crying and discomfort. So identifying dystonia becomes extremely important because this is very, very painful for the child, very problematic for the child. And it can be, I would say, not sometimes we can treat it very successfully, but at least we can give some kind of relief for the children. And there is a scale for this, and it is called Unified Dystonia Rating Scale. As you can see, it's a huge scale, but we can always use it from the internet, even on the wards, and make a note of it. Next slide, please. Next slide. So this is the dystonia scale. And I'm sure you have seen this in the pain class. So this is called revised FLAC-R scale. FLAC is an acronym for, as you can see, face, legs, activity, cry, and consolability. This can be used from 1 year to 18 years, especially if the child is non-verbal. If they are verbal, neurological conditions, we always ask them how much their pain is. But when they are non-verbal, we use FLAC-R scale. Again, documenting this is so important to give proper pain control for the child, right? Next slide, Vinila. And this is the non-communicating child, pain checklist. This is another one that we can use. This is something we can take copies, make sure that we are always documenting these for children, and we mark it and we give the score accordingly. Next slide. So when I mentioned severe neuroirritability, and all of you have brought it up, I really like this picture because it is very organized from head to toe. And every time we see a child with a neurological condition and lot of cry or discomfort, I'm always thinking, is this child in pain? And if it is pain, what scale to use? Then based on the condition, could there be increased intracranial pressure? And as you rightly said, oral problems which are not evident, sometimes they're just teething, but sometimes they can have dental caries, right? And always checking their ears, because a lot of times they're fed in lying positions and they end up having recurrent ear infections. And one surprisingly common thing that you will see in these children is inturned eyelashes sometimes, and that itself is irritating them. And just removing that eyelash from there relaxes them. And then corneal abrasions, when they don't close their eyes frequently, this is something, again, we see quite a lot. It seems unnatural to be discussing it, like how can this happen in our practice? But it does happen quite often that for a few days when the crisis is going on, no one looks at the eyes of the child and they don't close it, and they end up having corneal abrasions and a lot of pain because of that. And also looking at, are there contractures, as you all rightly said, and is there any joint pain? Is there any pain when we move the limbs? And when we look at the abdomen, again, because of multiple reasons, they have gastroesophageal reflux. And most of the times they're put on milk as the sole diet. And that itself sometimes precipitates constipation. They have food intolerance, gallstones. So these could be some of the causes. Again, we have mentioned bladder issues, incomplete emptying of bladder leading to UTI. Again, this seems like something very commonly that pediatricians should pick, and we do pick, but sometimes we do miss also. So just keeping in mind that whenever we see a child looking for pressure sores and things like that. And when we rule out all these conditions, if the child is still in pain, then the child has severe neuroirritability. Next slide, please. Before I go into it, if there are any questions, you can always type in the chat because we could interact in between too if these are important questions. So these impairments, as you all know, as you have all mentioned, do cause a lot of problems, including recurrent infections and, as you said, unable to take care of themselves. Next slide, please. And there are many, many complications, one of which I have not mentioned is epilepsy. What we see in community, especially, and I could see Dr. Archana, Dr. Gayatri joining in, and I'm sure Kritika must be seeing too, is they stop going to pediatricians after a point. The reason being, when a new diagnosis comes up new, the family goes to multiple hospitals for multiple opinions. And every one of them is saying, this is not curable, this cannot be gone. And after a point, the family depletes their resources and they end up saying, okay, this is what we have to live with. And they stop taking the child to the hospital unless there's an emergency. So what happens is, when we see these children in community, like the girl, the case scenario I shared with you, they're 14 years old. And the last time they have seen a pediatrician is when the child is 5 years old. And the child, when 5 years old, was 10 kilos, 12 kilos. And then they are on valproate or levetiracetam or phenytoin at that weight. And now the child is 30 kilos, but the child is still getting a very minimal dose of anti-epileptic. And they end up having these recurrent seizures, which are distressing to the family, but they don't go because the doctor said anyway, it is not going to decrease, right? So when we see them in community, just increasing the dose based on the weight has given them so much relief, and it looks like magic to the family. But, counseling them that these drugs need regular follow-up. And even though we do that, sometimes they do not come. I understand that. That becomes very, very important. And many of you have brought up about menarche. And can you type on the chat, what do you do in your practice A 14-year-old girl who has attained menarche and has regular menstrual cycles, and mother tells you it's becoming very difficult to handle that because there have been even issues where the child is not comfortable with the sanitary napkins and tends to pull them out, and it's very distressing to the family that she pulls it out in the house with when other people are there around. So any of the pediatricians, what do you do? What do you suggest the family to do? Anything on the chat? Yeah, it's a tough one, right? Because yes, Dr. Nagaram, you're right. We usually go with hormonal therapy, definitely. Hysterectomy, it is kind of a little difficult, discussion because if we are able to manage with hormone replacement therapy and manage it, that would be easier. A lot of times what people do is they use it for 3 months, the hormone replacement therapy, and then give a break. And the child has her menstrual cycle, and then they restart the child on hormone replacement therapy, right? So just remembering, trying simpler things, and there are families which advocate for hysterectomy, but I think it is very, very a huge ethical dilemma that we shouldn't be encouraging. I opine. I think even Dr. Kritika is saying the same thing. It is not usually advised. And the other thing we do have to remember is these children are at risk of abuse, because a lot of times these families might leave the child with the caregiver. And sometimes, again, we have seen in community that they just tie the child, uh, uh, with a rope to the window, or put them outside and ask a neighbor to take care of them and things like that. So just being mindful that they might be at risk for abuse and helping them out. Menstrual cups might be a new thing, but it might be a little difficult, especially if the child is not cooperative. And yeah, I think if the family accepts it, I think it is something that can be tried. But the most common recommendation is try hormone replacement therapy. Next slide, please, Vanilla. And also you have brought up about silaria. And one other thing we did not discuss is fractures. This is the other thing we look for when the child is in pain. It's because most of the time their mobility is limited and they are at risk for osteoporosis. And I saw that some of you have mentioned physiotherapy. If initiated early, it can help. But once osteoporosis sets in, a lot of times physiotherapists do not agree to start physio because they are at risk of fracture. So it's like a cycle that the child gets stuck in. And I have seen children being even prescribed bisphosphonates, oral and IV sometimes. But again, this has to be done, especially IV has to be done in a hospital setting, and it involves money and looking out for reactions and things like that. So this is something else that can be dealt with after a DEXA scan, and bisphosphonates, calcium supplementation, vitamin D supplementation. Scoliosis is again a tricky one. I haven't seen anyone get operated for, scoliosis as much in India. Again, maybe because I haven't worked in a high income setting in India. It was mostly with at a tertiary government hospital. But again, when you look at high income setting, they do go for spine surgeries, and it may, especially when it affects their respiratory function. So that is something else people do for scoliosis. Next slide, please. So, and in palliative care, we always talk about not just the child, but also the family. Just remembering that there is caregiver burnout, a lot of financial burden that comes with it, depression, why this is happening, especially if there is a second child who gets affected with the same thing. It makes life so difficult for the family. So they need support systems, and they might not always have it. And then the spiritual part of it, the feeling of punishment, why has this happened to us? I've recently seen a child who was dropped after birth. The child was born normal, no issues, no hypoxia. They dropped the child on the head in India, but I've seen the child here. And the child ended up having a hemorrhage in the head and is now bedbound completely. So like the parents' guilt, like, did I do a wrong thing going to that hospital and things like that? And sometimes father abandons the child, sometimes mother abandons the child, right? So just when we see the child, we see the child, but there is a lot of distress in the background that we might not be privy to, especially in busy OPDs. So just remembering that this is possible, and there might be reasons for their non-compliance, there might be reasons for them not turning up to our OPD on time, and things like that becomes important. Next slide, please. And also neglect, social isolation. Families cannot attend functions sometimes, they don't choose to attend. And even the child, they don't want them to mingle with other kids, especially if they're having certain behavioral issues. And if they look different. The other day, I saw a child in a lift. I didn't realize it was a child because the child was all wrapped up in cloth. So I was thinking maybe why they're taking a wheelchair, like for laundry. But then I realized the laundry was breathing, and then I realized it's a child underneath. But I don't know how the child looked because the mother kept the child covered. So like I couldn't see that there was a child under all that cloth. So sometimes that leads to social isolation and impact on siblings. If the parents are very caring for this child, they end up neglecting the healthier siblings sometimes because they can manage themselves. And it's the opposite sometimes. Sometimes they neglect this child and the sibling gets all the attention. And unrealistic parental expectations, and this can give a lot of distress to the family. And also, as I said, sometimes just because they look different, they might not have equal opportunities like other children. So sometimes, even as pediatricians, it becomes our responsibility advocating for this child to have equal opportunities. Next slide, please. So what do? We discussed a lot about what can be done, and some wonderful suggestions from all of you. Next slide. So always having appropriate goals. When we see a child, especially with those with palliative care needs, having a care plan, having proper communication with the family, and all of this has to come with assessment of family's capacity and what they can access. If I tell them go to a physiotherapist every day for the next 6 months, and if they're not able to buy food, that is never going to happen. Or if I tell them give the child Pediasure, and I know the father is earning 150 rupees per day, it is never going to happen. So just being mindful of what we are advising the family, which we definitely do a lot of time, but also what the child needs. So kind of balancing that becomes very, very important. Next slide. And also, as I said, documentation becomes very important for these children, especially when we are going to follow them again and again. So just looking at all the things that they can do, all the things that they cannot do, and how do we all, sometimes we even have to make a rehab plan and a rehabilitation plan in palliative care. Next slide. Also, you people mentioned physiotherapy. So whenever we have access to speech language pathologist, occupational therapy, or social worker, it becomes important to access them. Next slide, please. And this is a favorite word for all of us, goals of therapy. Yes, personalizing a plan for each child, Kritika, you're right. So just making sure what are the difficulties the child is having, the top priorities, and based on that, having a medical management, having a multidisciplinary team management becomes very important. I think my side of the presentation ends here, and Dr. Hariprasad sir will take over from here. Over to you, sir. And any questions till now? I know this sounds like a very common thing that all the pediatricians do. And I know some of the things I mentioned do require some extra resources. But as children live longer with neurological conditions, it becomes imperative that we as pediatricians apply some of the palliative care principles to make their life a little easier. Over to you, Hariprasad, sir.
Okay, so thank you, Spandana, for that elaborate presentation, and thank you, Team Hyderabad, for taking this program forward. So, Vinila, can you just go back? Just we'll probably start from there. Okay. So, at the outset, I thank all the pediatricians for joining our course. I know all of you are very busy practitioners and sparing 1.5 hours every week for 12 hours. For 12 weeks is not a simple thing. And I congratulate you for joining this course. And I'm sure at the end of the course, you will be more excellent pediatricians, and you will be practicing pediatrics with a lot of heart and brain in each patient. So, Spandana discussed about the various the conditions of neurological conditions needing palliative care. So now let us discuss how are we going to manage these children in our practice. So generally, when we discuss with the children with neurological illness or neuromuscular disorders, we always talk about a multidisciplinary team. But practicing in India, I think it is extremely difficult to have a team of our own. For example, myself, I am a faculty in pediatrics in medical college, government medical college, and you know, it's very difficult to have a team. So if there is no team, my advice is to you be the team. So in most of the cases, I'll be the pediatrician, I'll be the physiatrist, I'll be the physiotherapist, and I will do a little bit of counseling, and I will do a little bit of homework in the social aspect, etc., etc. So don't neglect a child with a chronic neurological illness just saying that I don't have a team along with you. So, but you please be act as a team. So that is my first advice to you. Okay, next slide. So, Spandana already said those. So these are the goals of therapy. And again, as Dr. Krudeva suggested, we should have a personalized plan for each and every child who is coming to our management. Okay. So our goals of therapy probably will, if I put forward, I will modify this as one focusing on activities of daily living. So ADL is very, very important. So a child who is able to meet his daily needs is practically will cause less burden to the family, and he will be more competent. He will be having more self-confidence also. So that's probably the most important thing. And second, as is already mentioned, is the prevention of contractures. Mobility is very, very, very important, and help them to communicate with us is again another important aspect. And definitely the comprehensive management of the family as a whole. That is very important when we deal with the goals of therapy. Next slide. And again, I request all of you to share your slide experience, because all of you will be managing children with cerebral palsy or neuromuscular disorders, and you will have some exposures. And so I request all of you to share your experience. And if you have got any doubts, probably we can have a discussion also in detail. So next is the spasticity. We know it can be managed by non-pharmacological measures, that is stretching exercises. And we have got a positioning is very important, like braces, wrist splint, etc. That will reduce the amount of spasticity and the prevention of contractures. Next slide. So that is a management of contracture. And then if they are not getting controlled with that, we go for the medications, and the common drugs we use is diazepam, baclofen. And remember, baclofen is a centrally acting muscle relaxant, and sometimes the muscles become hypotonic. So always weigh your the adverse effect with these effects. And whenever we deal with the spasticity in children with cerebral palsy, we should always focus on a functional level of rehabilitation. If it's a normal child, probably we'll aim for normal tone. But in cerebral palsy and other conditions, sometimes some amount of hypertonia and some joints will be helpful. That will increase their activities of daily living. So always focus on the functional level of rehabilitation. And again, baclofen is a seizurogenic drug, so always keep on the watch out for seizures also. So these are the two drugs which are generally used, diazepam and baclofen, and sometimes we go for trisanidine also. And if it's localized spasticity, we can give injection botulinum toxin, and one injection the effect can last for about 3 to 6 months. And in the central government scheme, there's a program called Niramaya scheme, where we can, or under the RBSK program, that is a Rashtriya Bal Suraksha Karyakram program, where we give treatment free of cost for all children across India less than 18 years of age. We can give injection botulinum toxin free of cost. And if that is not possible, then we will go for the surgical correction. So that is regarding the minimum spasticity and contractures. Next slide. Next slide. Okay. So I think this is again a pictorial representation. Okay. Next slide. Okay. So this is again positioning. I think we had discussed in detail, and all of you know the importance of positioning and other non-pharmacological measures. Next slide. Again, mobility, I think, as I told you, and the most important 2 points we should stress is, one is ideal, that is activities of daily living, and second is mobility of the child. So whenever possible, we should be able to make the child mobile as much as possible. Okay, next slide. So I think well, a few questions are there, probably. I hope Spandana will answer these questions in the chat box. Okay, so okay, so next is seizures. So as Dr. Spandana already said, we have to titrate the dose of anti-epileptic drugs based on the weight of the child. And please remember that fever is a precipitating event. So whenever the child have fever, please give paracetamol at a dose of 15 milligram per kg per dose. Some disturbances there. So whenever there is fever, you please give paracetamol at a dose of 15 milligram per kg per dose. Maximum we can give 5 times a day, and you should give clobazam along with the paracetamol, because that will bring down the threshold of fever. And all parents should be equipped with midazolam nasal spray, because giving midazolam nasal spray, which costs about just 250 to 300 rupees, will save a lot of time and also a lot of money, as well as panic among caregivers. So please manage the fever of all these children with appropriate dose of paracetamol. Along with the first dose of paracetamol, you give clobazam, and also teach them regarding use of midazolam nasal spray. And another point is, sometimes they may not be able to swallow, and so always keep rectal paracetamol as well as rectal diazepam as an alternative for all these children. And another important point is, one is dystonia. You know, the cause of dystonia is a simultaneous contraction of the agonist and the antagonist. So it causes severe pain for the child also. So, and again, beware of some drugs, because some drugs can precipitate dystonia. And again, any form of pain of stress can aggravate dystonia. Then the common drugs used is, one is levodopa, second is trihexyphenidyl, and the tetrabenazine. So as pediatricians, please don't refer these children to neurologists for starting these drugs. We are equipped and we are competent to start all these anti-epileptic drugs as well as anti-dystonic drugs. Next slide. So another important symptom, I think this Spandana has already discussed regarding that. That is agitation or the neuroirritability, which is very common in children with the neurological illness. And what is agitation? So these are episodes of inconsolable crying or sustained active behavioral disorder, behavioral state. And practically speaking, they'll be going on crying. And if you examine from head to foot, probably you may not be able to find a cause for that. So practically speaking, this is so distressing to the child and the family, and it is not rare also. Next slide. So, so how will you rate agitation? Or so this Spandana has already mentioned regarding the scale. That's a NCCPCR. That is a non-communicating children's pain checklist device. So whenever a child is having symptom like agitation or neuroactivity, you please spend 5 to 10 minutes for the child. It is given under 7 headings, that is a vocal, social, facial, activity, body limbs, physiological, eating and sleeping. And you please score, there is a score from 0, 2 and 3, and any score of 7 or more indicates the child is having some amount of agitation. Next slide. So what the basic principles in palliative care is always under, management is always under 3 headings. That is the corrective, the correctable, non-pharmacological measures and supportive measures, and finally the supportive measures. So look for a head-to-foot examination. Spandana showed a beautiful picture showing what are the important problems to be looked for from head to foot. To have a detailed examination from head to foot. If there is any correctable problem, you correct that. Second, you support the child, that is appropriate positioning, appropriate room, managing the child in a very quiet environment, in a comfortable position, and correcting dehydration, etc. And then the common drugs used for agitation are, one is the gabapentin, that's a drug of choice, and sometimes they may respond to amitriptyline or chloralhydrate. So always go by these measures: correct the correctable, supportive measures, and finally gabapentin, amitriptyline or chloralhydrate. Next slide. And another symptom that we come across in all these children are the breathlessness. We know there are a lot of reasons for the breathlessness of this child. They may have kyphoscoliosis, they may have aspirations, and they may have pulmonary hypertension, they may have polycythemia because of the chronic hypoxia, etc., etc. They may have altered sleep. So all these causes contribute to breathlessness. So what are the evidence of breathlessness in such a child? One, child will have cough. Sometimes it may be ineffective cough. The only evidence may be tachypnea or increased blood flow breathing. Sometimes the children will have a disturbed sleep and somnolence. And also any child who is irritable in the daytime, you please ask whether the child is having comfortable sleep. And so if the child is, sometimes the child will hold the head and go on crying, and that may be because of the altered sleep rhythm or hypercapnia leading on to, or hypoxia leading on chronic headache. And sometimes child will have the only evidence of maybe polycythemia of hypoxia. So these are some varied manifestations of breathlessness. Next slide. Okay. So how will you manage? So one is correct the correctable. You know there are various conditions. One is it can be aspiration pneumonia. You give with antibiotics. There may be GERD. We can discuss GERD in the subsequent slides. So find out any cause that is correctable. You treat that. Then our main aim is normal oxygenation. That is check at the SpO2. And if the SpO2 is around 94%, you should be comfortable. So sometimes the child may need oxygen concentrator. And now nowadays, if you spend around 25 to 30,000 rupees, you can get oxygen concentrator. The only thing is they should have a continuous current supply. And in Kerala, we have got a policy where homes with oxygen concentrator, the government makes use this electricity free of cost. So find out if there is some facilities like that. So either we can go for oxygen concentrator, or sometimes they may need other machines like CPAP or BiPAP machine. And another important aspect is clearing the airways. So how do you do that? One is hydrate the child adequately, because this will thin out the secretions. Then position the child like log roll about chase the position child about 4 to 5 hourly. That is postal drainage will facilitate. Then manual vibration. Sometimes you can go for abdominal binders that will facilitate airway clearance. And sometimes you can use you can teach a caregiver for oropharyngeal suction. So all these measures will bring down the amount of breathlessness to a great extent. Next slide. So another very common problem that we come across in these children is increased secretion. Choice is glycopyrrolate, but in practically speaking, I have given homatropin eye drops, because this is very easily available and is very cheap also. So if you give a few drops of homatropin eye drops, which is applied by ophthalmologist in the eyes, that will solve, that will solve the problem. So if glycopyrrolate is not available freely, or if they cannot go and buy that, or if any the reason they cannot afford that, then we can go for homatropin drops. They are very cheap, and that will serve the function. That will bring down the amount of increased secretions. And again, we can nebulize a child with 3% saline. That will thin out the secretions. And as we already discussed, physical therapy over the abdominal triangle muscles will again facilitate secretion, removal of secretions. And immunization is very, very important. We should immunize all the children with all the vaccines of UIP. Along with that, we can give influenza vaccine, because the commonest cause of getting infections is the healthy sibling or the parents coming from work and giving and having a close contact with the child, and the child gets in the infection. So if you give seasonal influenza vaccine, that is once in a year, probably that will solve the problem. And also please give pneumococcal vaccine also, because another important etiology agent for all these infections, pneumococcal. So there was one question on the chat regarding the homatropin drops. We just give 3 to 4 drops. Homatropin drops actually is applied in the eyes, so that it is very, very diluted. That is 0.1% is very diluted, very low strength. So you can titrate the dose based on the need, and just 3 to 5 drops is needed. Homatropin drops can decrease respiratory, definitely. Homatropin eye drops can decrease the respiratory secretions. Okay, and the frequency you can generally apply. I asked the mother to give twice daily or 3 times daily, and a few days later the mother will become an expert, and they will come and tell you, no need, sir. I will give just 2 drops twice daily. That is enough for my baby. So probably they will be able to titrate. Okay, so I told you regarding the development of pulmonary hypertension. And please remember that any child with a kyphos scoliosis or repeat aspirations, etc., are prone to have pulmonary hypertension. So this this pulmonary hypertension per se can lead on to malignant arrhythmias. And sometimes these children have a sudden death because of pulmonary hypertension, leading on to malignant arrhythmias. So it is always better, if possible, to have an echocardiogram at least once in a year, to monitor for pulmonary hypertension. And if the child has got pulmonary hypertension, you can give drugs like nifedipine and sildenafil, and that will significantly improve the quality of life in children. Yes, eye drops is given orally. Yes, okay. Please don't apply these eye drops in the eyes. It is for to thin out the thick out the secretion. It should be given orally, not in the eyes. Okay. Next slide. Okay. So having discussed the main conditions, that is seizures, spasticity, contraction, secretion, we look at the other pharmacological interventions. Next slide. Okay, so I'm sure all of you know that the 2 main conditions or indications for morphine children with the palliative care. One is pain, and second is respiratory distress. So generally we have got a notion that morphine will cause respiratory depression, and all the pediatricians, practically speaking, are very much afraid to give morphine in a child with a respiratory distress. So here in our setting, we give morphine for all children with a respiratory distress after correcting the correctable measures, because the morphine will bring down, will give an apparent relief of dyspnea, and will increase the respiratory center to tolerate hypercapnia. So morphine, I repeat, morphine is the drug of choice for children with respiratory distress in palliative care setting, and the dose is very small dose, that is 0.05 to 0.1 milligram per kg per dose, 6 hourly, and that is given orally. It's not it is always given orally. Okay, and any handwriting morphine should prescribe a similar laxative like Dalcolax, and another drug, an antiemetic which acts on the chemoreceptor trigger zone. And the 2 common drugs we use is metoclopramide and domperidone. Please remember that metoclopramide is one drug that can cause extrapyramidal reaction like dystonia. So if possible, I prefer to go for domperidone. So then again, domperidone is needed to be given only for the first few days, because the morphine, the antiemetic dose, the effect of morphine will slowly subside. So you give domperidone or metoclopramide for the first few days if the child is having nausea, vomiting. But you should continue to alkalize as long as the child is on morphine. So morphine is the drug of choice, which is given orally at a very small dose at 2 to 3 times for respiratory disease in palliative care setting. And you please prescribe Delcolax and antiemetic like metoclopramide or domperidone. Next slide. So what's the role of benzodiazepines? So the role of benzodiazepines is in child with a respiratory disease, even after giving morphine and all, if the child has got severe panic attacks or there is anxiety, we can give a small dose of benzodiazepine in the form of lorazepam or midazolam, and these are anxiolytics as well as that will sedate the child also. And this will, in the pharmacology, this will not cause respiratory depression. So they got 3 effects. It is reduce the anxiety, reduce the panic, it will sedate the child, and that will also not cause respiratory depression. So lorazepam, a small dose of 0.05 to 0.1 milligram per kg per dose. It's a short-acting drug. We can be given 12th hour or 8th hourly, or we can go for midazolam. It's again a small dose of 0.05 to 0.1. That is this is a sub-Q infusion, but we can also give oral midazolam. Okay, next slide. Okay, so another very important or another major symptom that we have to manage in children with a chronic neurological illness is the gastroesophageal reflux disease, because we know that yes, definitely midazolam nasal spray can also be used. Okay, so GERD, that is a gastroesophageal reflux disease, is one of the most important cause for repeat aspirations and also for hospitalization of the children. So how to manage GERD? One is smoke can aggravate GERD. So please avoid smoke, and so that it should come under the correctable, and always position the child upright, especially before feeding, and after feeding the child should be positioned such a way for at least half an hour. Okay, and then giving very thin feeds is another important problem for GERD, because their lower esophageal sphincter is very loose, and their child is prone to have aspiration. So thickening of feeds. So thickening of the feeds, increase the frequency of thickened feeds, and please elevate the head after feed. And generally, we have got a tendency to keep the head end of the bed elevated, but that should be discouraged. Instead of that, the head should be elevated after each feed. So elevate the head. Avoid acidic foods because that will aggravate GERD, and these are the common drugs that will aggravate the GERD, that is a tomato, chocolate, juices, and caffeinated and carbonated drinks. And please do not use pillows for elevation, because these are very common errors that parents do in the family. And any child having significant GERD, you can control that with a proton pump inhibitor in the form of pantoprazole or lansoprazole, along with the domperidone. And domperidone 0.2 milligram per kg per dose 8 hourly, and PPI given once daily. And if the child has severe spasticity, you treat with baclofen, because I told you when the abdominal muscles are very rigid, that will precipitate GERD. So you please manage the spasticity with baclofen also. So all these measures, that is appropriate positioning, thickening of the feet, avoiding the acidic foods, elevating the head, using appropriate dose of pantoprazole, domperidone, and managing spasticity will bring down the GERD to a significant extent, and we will be able to avoid hospitalization of these children as much as possible. Next slide. Okay, so these are what are the general measures. I think all of your pediatricians, I will just hurry through, because so whenever a child is brought to you, please address the nutrition. And generally what we recommend is 80 to 100 calories per kg per day and 2 grams per kg per day. And no need of discussing about sunlight exposure and vitamin A prophylaxis to pediatricians. So you please concentrate on this macro and macronutrients. As we already mentioned, please ensure that all these children are vaccinated under UIP schedule, and please give influenza and pneumococcal vaccine appropriately. Next slide. So, Spandana already said, I must say that the commonest cause of source of infection in all these children is dental caries. Probably more than 90-95% of children with all these children are having some amount of dental caries, and that is will focus the focus of infection. So annual checkup of this dental caries is very, very important, and always ensure that if there is any vision or hearing that is treatable or correctable, you please correct that, because that will go a long way in rehabilitation. So periodic follow-up of vision and hearing and evaluation management is very, very, very important for these children. Next slide. I think so. We have already discussed feeding problems, spasticity, GERD, and aspiration. And another problem is the pseudobulbar palsy, you know. And in Western world, probably they advise that is a pediatric gastroenterostomy for all these children. But in our setup, probably it may be difficult. But practically speaking, if you have got a very close friend, like even a surgeon or a pediatric surgeon or interventional intensivist, there probably they are. We can request them to go for a PEG, but if that is not possible, we can go for a rice tube feeding. Okay. Next slide. I think we already mentioned excess secretions giving homotropin drops. Then, okay, another important issue is constipation. So generally, they fail to chew, and the parents will always give food that is very poor in fiber. So as much as possible, you give a diet that is rich in fiber, and we can also avoid constipation by giving stool softeners, laxatives, and also appropriate hydration and positioning of the feet. And please remember that the neck of the bladder press upon the rectum. So if there is constipation, that will press upon the lower rectum will press upon the neck of bladder, and they will precipitate UTI. So avoid constipation, because constipation will lead on to UTI. And you know that all of your experts are in bladder, and we know that depending upon the level of lesion, they can have different types of bladder. It can be a neurogenic bladder, spastic bladder, autonomous bladder, etc. So depending upon that, you assess the bladder and you give the drugs appropriately. And also, if needed, conditional neurogenic bladder may need clean intermittent catheterization. So our aim is to prevent UTI, to prevent stagnation of urine, and also avoid constipation. And please remember that any child with neurogenic bladder or loaded bladder will have a reflux that will lead on to vesicular reflux, and that will lead on to renal tubular damage, and the child may develop chronic renal failure by the time child is in the 20s or 30s. So please remember that even our simple measure of not correcting constipation or not addressing the issues of bladder will go a long way in giving or making the child more suffer by the time he's an adolescent by resulting in chronic kidney disease. So you please address this. Okay, next slide. So I think yes, Spandana already mentioned it, but this year I will just go through this, because this was a just study did in my own department in Toronto Medical College. So you just look at the psychological issues of the caregiver. So practically speaking, almost all of them are distressed, and they are socially embarrassed, and they don't have any leisure time. And even if the mother is with the child throughout the day and time, that shows that the information that we pediatricians pass on to them is inadequate. So from today onwards, whenever you deal with such children, you please pass the information appropriately and in detail, and make sure that the child, the mother has understood regarding the condition. Next slide. Okay. So probably the most important single group that we ignore in all these families is the siblings. And again, this is our own data, which shows that there was no one to lend their ears for the siblings, and they were not at all praised or rewarded, and the caregivers failed to spend quality time with the mother. Next slide. And you can see the out-of-pocket expenditure. So please remember, this data is from a tertiary care center in government center, where we say that all these their expenditure are met under RBSK. So even in such a setup, 80% of the family income was spent for the child with chronic neurological illness. So that means the out-of-pocket expenditure for such children is huge. Next slide. Okay, so when such a child is taken to a nearby hospital, what will happen? So probably they will have only OP. Sometimes it will be a single man doctor and the doctor will be on leave. Sometimes the parents will not be satisfied because they think that the care given was not appropriate. And generally what will happen, the doctor who sees a discharge card from a tertiary care center with a thick book, and they will not see the child in detail and they will refer the child immediately. So this is happening. So as a local pediatrician, my request to all of you is to empower the child and the caregivers, as well as to have a communication with a local doctor who is treating the child or who is sitting in the nearby primary health center, so that if we have a one-to-one relation with the treating doctor, we can save a lot of money and time, and we can bring down the lot of difficulties of these 4 families. Next slide. Okay. So again, the transport in our setup, we know the difficulty in getting a transport in a government sector. So again, in our own study, we showed that, and generally we think that Kerala is well connected by rail and road and all, but still they had to spend 500 rupees per visit. Next slide. So having discussed the various issues and having discussed the various the conditions in palliative care, we discussed the various issues. Now let us discuss their needs. So what is the need? So what is our primary duty as a pediatrician? So our primary duty as a pediatrician is to act as the principal clinical provider, so that, okay, I'll just finish within 10 minutes. Okay, no problem. Okay, so please act as a clinical principal caregiver for all these children. We should help them to have a shared decision, and please ensure that there is some access for whenever they have an urgent problem. And as pediatricians, generally we tend to refer the child after 12 years to the medicine department, government setup, probably after 18 years in a private sector. But again, the transition is very, very important. We should always have isolate or find out one physician who has got some interest in managing these children. So transition nodal care is very, very important, just as we manage this children. Okay, next slide. So our duty is to help them in their needs. Next slide. And so how to meet them? So by proper symptomatic management, by proper communication, and also be giving meaningful hopes. So please, I just one word on that, because generally they will have a lot of expectations which are not or which will be very high. So it is primary our duty to give them meaningful hopes. That is, so we had to spend a lot of time in communicating also. Next slide. So the answer for all this is palliative care and started diagnosis. Next slide. So how does this help? Next slide. So if we manage these children appropriately, what is the gain for the families? We know that we can bring down the days of hospitalization significantly. We can revamp the family support system, and there will be significant improvement not only for the child but also for the child siblings. And probably the most important thing is we can make all the family members accept the illness, and they will have only meaningful hopes in the future. And we can also bring down the financial burden of the family. So whatever is said and done, I think our primary aim is to improve the quality of life, not only of the child, but also of the family as a whole. Next slide. So to conclude, so we know that the medical science is advancing. A lot of, practically speaking, all the babies are salvaged in the newborn period, whether it's an extreme preterm of 28 weeks, whether it's a syndromic baby, we have got an enhanced program, we have got a advanced program, and all pediatric, we have got a lot of intensives coming. So practically speaking, all the babies who are born in the newborn period are salvaged, but we have to look whether the quality of life of all these children is good or not. So with advanced medical care, a large number of children with chronic debilitating disease will survive and they need palliative care. So just because of that, we should be able to establish model centers who are able to provide comprehensive management in all the major hospitals. And we should also be able to provide community services, home visits whenever is possible. And we should also be able to address all these children, even if we are alone. We should be able to manage all these children comprehensively. Next slide. So we know that India is a huge country, a large country with a lot of diversities from north to south, west to east, lot of differences between urban and rural, the rich and the poor. So primary speaking, so I would request all pediatricians who are here today to spend additional 5 to 10 minutes whenever such a child is brought to us, so that we can manage all this, the symptoms of the children. We can address their social issues. We can address the psychological issues. We can address their financial and spiritual issues. So our primary aim is to focus on the quality of life of the child and the family as a whole. So I think that comes to the end of my talk. So thank you all once again. And once again, I thank all the pediatricians who showed a lot of interest and great enthusiasm for joining this course in spite of a busy practice. And I'm sure you will be coming out with so many suggestions so that we can have a lot of learning experience from you also. And it's open for discussion. So over to Spandana, Kritika, and Vinila. So any questions in the chat? Spandana, I think we have answered all, or anything remaining?
Which we answered it on the go while the sessions
Okay.
are going on.
Right. So I got, I think, just probably 10-15 minutes more. If any suggestions, or they can share their experience, or they can tell us their experience, so that we will also learn.
Skin care. Dr. Himanshu's question is about skin care for child.
Spandana?
Yes, sir. I think definitely one common thing to think about is that most of the times, if they're in lying position, just making sure that they're turned to sideline positions. And even what we see is when they're placed on the side position, when the knees lie on each other, they start, because of the friction, there is skin breakage. So making sure there is a cloth, a pillow kept between the legs whenever the child is turned, the back is supported, and even how the mother examines for the skin changes is important. I think that is one part of it, the bed sore part of it. The other part of it is, we did mention nutrition. So sometimes they're not getting enough nutrition. So there are vitamin deficiencies, and that itself can manifest as skin issues and cheilitis and things like that. So making sure we look for that. And sometimes parents are also actively trying a lot of food items. So there can be food allergies. So I would say looking for that is one part of it. And regular skincare, like moisturizing it with simple things, like maybe use oil, maybe use Vaseline. And I think the fifth thing I would think is diapers. Diapers and sanitary napkins, when they use, having a localized rash is one more thing that we have to be mindful of. So when you examine the child, irrespective of the age, I think if we should have a chaperone or a parent next to us and examine head to toe for these children. I think these are very important. But Kritika, Hari Prasad sir, or any other participants, if we can think of other things, I think it will be good discussion.
Sometimes even I do is that where you mentioned the knees are together, joint, and so I kind of tell children, I mean my parents, have water balloon filled with water. Sometimes in that buoyancy at certain joint areas where they're not able to avoid the friction, but in between, if it is slipped under those areas where the joint is there, or the bones are like very cachectic and the bone is almost is the skin and bones. And to avoid the friction, we just say place that water balloon for some time. If they're not able to afford a water bed or a air bed at that point of time, then that also helps to avoid the pressure source.
Okay. So I would like to add, because I think Spandana mentioned about vitamin A and D, because all these children are prone to have vitamin deficiency, especially D, because they are not at all exposed. So please, no need of checking the vitamin D level, but instead you give 1,000 to 2,000 internal units of vitamin D daily, and plus expose the child to sun at least for a half an hour, at least 4 to 5 times, 4 to 5 days, okay, at least for half an hour. So that will solve a lot of problem, because rickets can definitely bring down the aggravate dryness of the skin, and that will reduce the muscle tone, and so that will have, of course, contractions also. And another is you give vitamin A, because vitamin A is absolutely needed for the skin and the mucous membrane. So vitamin A, we know that we have got a national program for vitamin A where give 9 doses from 9 months to 5 years. But generally, all these children are not at all getting vitamin A. So you please give, follow all my request to pediatricians is you please follow the national program for all these children, just like it's a normal child. And then Spandana mentioned all other measures, positioning, vaccine, and etc. And the only thing is, please don't spend a lot of money for skincare, because a lot of costly lotions have come up, and some others spend a lot of money for giving skincare, and they compromise on other major drugs. So that should not be addressed. That's anything, any suggestion?
So Prashant's suggestion is these children always on anticonvulsants, which produces hypocalcemia and vitamin D deficiency. That's why they were asking about monitoring.
Yeah. So I think so. Generally, the anticonvulsants which predominantly causes this is the phenytoin. Okay, the phenytoin sodium. So our practice generally, personally speaking, I will try to reduce and stop phenytoin if possible. And we have levetiracetam is a very good drug, and is a very broad spectrum anticonvulsant. And I'll try to maintain them on levetiracetam. And another drug is sodium valproate, because sodium valproate, one, it causes vitamin D deficiency, and also it if it is given in children less than 2 years of age, that can precipitate Ray's syndrome, because it's a hepatotoxic. So that's also an important message we have to convey. And if the child is on valproate, and if the child is an infant, you place as much as possible, you please try to change to levetiracetam. Okay. And if possible, you try to slowly reduce the dose of phenytoin and taper and stop. Most of the time, that is possible. And because the dose of levetiracetam is a wide range from 20 to 60. So if you increase the dose of levetiracetam appropriately, most of the time you will be able to bring down and stop other anticonvulsants.
Was about should we do a vitamin D levels regularly before prescribing, or start at a daily dose, and what should be the dose of vitamin A?
Vitamin D.
Vitamin D as a daily dose of 400 international units, and what should be the dose of vitamin A?
No, I think the vitamin A, because if you give the green leafy vegetables and also the fruits, that is okay for the vitamin A. Okay, and we know that all children from 9 months of age to 5 years of age are getting vitamin A. And at 9 months we give 1 lakh, and from 1 year or 1.5 years to 5 years we are giving 2 lakhs units every 6 months. That means we are giving 5 doses. And 9 doses from 9 months to 5 years. And the vitamin A is a fat soluble vitamin, and that will remain in our body for quite a long time. Okay, so practically speaking, that is enough. And plus you give adequate GLV and GYO. GLV is a green leafy vitamins, and GYO is green, yellow, orange fruits. So I think this will take care of the vitamin A deficiency.
Some of the questions Spandana is already answering up on the chat.
Right.
Anyone else has any questions?
They can come out their comments also. Comments, criticism, that is also very important because we have to improve every time. Okay. And next time, probably they will be also working as faculties along with us. So criticism is also important along with suggestions.
I feel that oil massage will be soothing for the skin as well as it will be some kind of physiotherapy to the child and a personal contact to the child, emotionally bonding. So that can also be included.
Yes, ma'am, definitely, madam. That emotional contact is very, very important. Yeah, I think we should not ignore the child because the child should be in the center of the team. If it's a family, he is the center of the family, and if it's a when he comes to our center, he should be the center of the treatment team. We don't address the disease; we address the child as a whole.
But I just want to add, sir, that one thing to remember about massages when started late, as I said, if the child already has osteoporosis, and we start very enthusiastic oil massage, we have seen children who ended up having hip dislocations and fractures. That is one thing we have to remember. And then I think there are some neurodegenerative conditions where oil massage is contraindicated in itself. But again, I think we need to ask a physiotherapist. I'm not saying every child we need to ask, but I'm not sure what those conditions are. Let me find out from my physiotherapist and I will share it on the WhatsApp group about situations where oil massage is not recommended. But I think otherwise, as you said, emotional bonding, it's very, very important. And I just want to say, last night and today morning, we lost, I wouldn't say lost, we had 2 children who died at our hospice. One is with Niemann-Pick disease, and the onset was very late at 7 years of age. Already elder sibling has passed away, and family chose not to go for ICU. And this child was on valproate, well-controlled seizures, but had aspiration pneumonia, recovered from aspiration pneumonia, but her lungs haven't recovered fully. She was on high flow. We de-escalated, and the child passed away 3 days later at the hospice. And the other child who passed away is a high-grade glioma, who is bedbound since 1 year with hemiparesis on one side and hemiplegia on the other side. And from 3 months, he is not even making eye contact or anything, but he just went on and on for 3 months. So these 2 children I'm mentioning because there are cancer conditions with this. And then there are some metabolic conditions that end up having neurological symptoms. And having palliative care principles applied also helps because the family makes peace with what is happening, but also the child is getting better medical care and proper end-of-life care when appropriate. Over to you, Kritika.
We had one more comment, like elder family members also encourage you to get them immunized. And then Mr. Srikanth had about keep talking to children, playing soothing music, and try taking them out. So normalize the whole process. Treat them as like a normal child and have it like that. So that way the bonding helps they come closer together. So it was a very wonderful session that we had. We had really good comments coming from all the participants where they shared their views, they share the various ways that we can help children. And Hariprasad sir and Spandana, you did a fantastic job to take through this, and we managed to have a lot of questions. There's one more question from Dr. Gopi Krishna. For pain and cerebral palsy, can we start morphine and for how long? Would you want to take that question, sir?
Okay, so I think I think we had discussed the pain in cerebral palsy is due to multiple reasons. Okay, so one, it can be due to spasticity, and if it is due to spasticity, we have to give muscle relaxers. Okay, and then it may be due to blood source. It may be due to some other condition. So we cannot say that morphine is a drug choice for children with cerebral palsy with pain. So most of the time, it will not be due to some other reason. So I must say, morphine is not the drug of choice for pain in children with cerebral palsy. You please find out the definitive cause. and address that, and most of the time that will be able to solve the problem. I will request Spandana to add on that.
Yeah, definitely, sir. I agree with you. The one other time we use morphine in neurological conditions is usually at end of life. And sometimes when we even start neuropathic medication like gabapentin or pregabalin, during that time as a short coverage period, we use it sometimes, but again, not in regular practice at all. So definitely that is one thing. And I also see I think hormone replacement therapy, because the gynecologists are not used to it, they are not going to do it very easily. So I think we have to educate ourselves as pediatricians how to do it and help our children. I don't think it is going to be very easy to convince gynecologists if they are not ready. But one thing to keep in mind is these hormone replacement therapies do interfere with anti-epileptic levels, because most of the times they are enzyme inducers. So just to be sure that starting this, we are not explaining to the family the risk of increased seizures and probably the need to increase the dose. So because once we tell them the risk, I think the family knows what we are doing and they trust us better. And as Kritika said, nasal midazolam, the spray, it is excellent. So giving the family that, I think they feel more empowered to try these new medications for their children.
I would like to add one point along with this. So because in my experience, I have come across some mothers who are very proud, saying that their daughter has attained menarche. So that is also another aspect. So I think we should always discuss with the parents in detail and find out whether they opt for that. So that is very important. Okay. So so communication is very, very important, and the decision is always a shared decision. So rather than suggesting hormone therapy, we should find out what are the is the mother happy with that. Some mothers may be happy because she takes her daughter as a grown-up mother, a grown-up child with all the features of a girl, of an adult girl child, and sometimes they will opt not to go for hormone therapy also. So I think also please keep this point also in your mind whenever you discuss about mental issues in such children.
Thank you. Thank you so much. So it was a wonderful session, and this brings us to the end of the session today. We will put in the link for the post test in the group here as well as on the WhatsApp group. I please request everybody to make sure that they complete this post test to move on to the next module. And the next session will be on next Saturday, 9th of September. And the topic is ethical based decision making and advanced care planning in children with chronic illnesses. And at session, we have two expert external faculty, Dr. Leslie Lewis and Dr. Manjri Dike, along with me, who will be taking that session for you. And I look forward to meeting all of you next week. Thank you, everybody, and have a good evening.
Okay, thank you.
Thank you all.
Thank you, everyone.
Vinila, there is a number on the chat who are not part of WhatsApp group. I think they're requesting you
Dr.
to add.
Ushma Singh has been not added.
So we have already sent this link to all the email IDs, ma'am. So they just have to click it and join. In the email, and we have sent that in the WhatsApp group. Sorry, we have sent it in the email for all the 450 participants.
Thank you, Vinila.
Thank you, Vanilla.